Hypertension is not a surgical issue, but there are some forms of secondary hypertension which will respond to surgical resection. That's going to be primarily the diseases of the adrenal gland and then coarctation. In the endocrine videos in medicine, we have these topics discussed in great detail. These are going to be a high-level view, rapid review of what we learn in those lessons so you get the answers right on your surgical shelf. Let's start off with aldosterone. The way aldosterone works is that it is produced from the little fat hat on top of the kidney, the adrenal gland. What aldosterone does is causes reabsorption of sodium in the collecting duct at the expense of potassium. It holds on to sodium so that when water is reabsorbed, water follows salt, you fill up the tank. This is done under the influence of the kidney via renin, which turns on Ang2, which turns on the adrenal gland to make aldosterone. Or there is a tumor that makes excess aldosterone independent of renin. If there's too much aldosterone, too much sodium in the body, you won't get a disorder of sodium. Your tank will just be too full, and that stretches the vessels, causing hypertension. And because aldosterone reabsorbs sodium at the expense of potassium, the patient is going to present with hypertension and hypokalemia. If you see hypertension and hypokalemia together, it is almost certainly going to be an aldosterone question. The first disease is primary hyperaldosteronism. This is Conn syndrome. The patient is going to present with hypertension and hypokalemia. And you've identified this as a disease of aldosterone. And what you want to know first is it because of renin or is it independent of renin? And so to do that, you determine the aldo to renin ratio. In the case of a tumor that's making aldosterone, irrespective of the system, aldosterone will be elevated. The kidney knows it's got plenty of volume, so it's not going to make any renin. Aldo goes up, renin goes down. The aldo to renin ratio will be elevated greater than 20. Just know that you should be off anything that influences this system, so off diuretics and ACE inhibitors when you do it. If you find the aldo to renin ratio greater than 20, you follow it up with a salt suppression test. You give an IV bolus or a large salt load to really hit the kidney hard, turn off the renin altogether, and see what happens to aldo. It'll fail to suppress in the case of Conn syndrome. Once you have that, you've got biochemical diagnosis, you need to find it. So you use some type of imaging of the abdomen, CT, MRI. But here's the new thing. Because 50% of adrenal gland adenomas that are determined to be biochemically hyperfunctioning end up not being functioning and the other adrenal glands are the one to blame, before you go in and remove an adrenal gland, you want to do adrenal vein sampling. Make sure that you've lateralized the hyperfunctioning adrenal gland before you remove it, because the treatment is resection. Now you compare that to renal artery stenosis, which is going to occur in one of two ways. It's either going to be the old man with atherosclerosis or the young woman with fibromuscular dysplasia. Old man or young woman, that's it. They're going to present with hypertension and hypokalemia. In this case, flow to the kidney is reduced because of renal artery stenosis. The kidney thinks its volume down, so tries to reabsorb more volume by increasing renin. In this sense, aldosterone is elevated, but so too is renin. So this ratio approaches 1 less than 10. Once you have the biochemical evidence, you want to find where the lesion is. To avoid damage to the kidneys, you do that with ultrasound with Doppler. Technically, the best test is an angiogram, and whether you do that with a wire or with a CT, it really doesn't matter, but unless you're going to intervene on it, you might as well not expose them to contrast. So the treatment then is going to be dependent on the disease. For the young woman who's got fibromuscular dysplasia, she should be stented. For the old guy, it's a plus minus. So say no to stenting or surgery and instead medically manage these guys by giving medications that block the problem with the system, ACE inhibitors or ARBs or aldosterone antagonists like spironolactone. That's aldosterone. Let's take out an easier one to give a breather. This is pheochromocytoma. Pheochromocytoma is a problem of catecholamines. Catecholamines are going to cause hypertension and tachycardia whenever they're exposed to the body. But because pheo produces catecholamines in excess in a pulsatile fashion, the patient is going to experience the 5 Ps. They will have paroxysms, because it's pulsatile and occurs randomly, paroxysms of elevated blood pressure, so high it will result in headaches called pain. Their heart rate will increase, so they'll have palpitations, and they will perspire. They will have these spells that occur throughout the day or through their life, alerting you to the fact that they might have pheo. If you're thinking pheochromocytoma, what you want to get is a urinary, and this is collected over 24 hours, VMA, and metanephrines. There are other tests you can do. Clonidine suppression test. You can draw their blood for metanephrines during the attack. Test answer is going to be urinary metanephrines over 24 hours. Once you have biochemical evidence of pheochromocytoma, you want to localize it, CT scan or an MRI, or in this case an MIBG scan, some way of identifying where the pheo is, and before you resect it, you need to do an adrenal vein sampling to make sure you've got correct laterality. The treatment is going to be resection, but these are catecholamines. So if you go poke a pheo, it's going to release all the catecholamines and then cause a hypertensive crisis. So you have to reduce their blood pressure and prepare them for that catecholamine surge. But catecholamines stimulate both alpha and beta, so you have to do both. And this is theoretical now, because this doesn't happen in patients who, say, are taking beta blockers and do cocaine, but it still gets tested all the time. Pheochromocytoma must first have alpha blockade, then beta blockade, then resection. And so it is either going to be the urinary metanephrines to make the diagnosis, or the fact that you must start alpha blockade first, which is usually going to be tested. All right, back to a hard one, Cushing's. Cushing's syndrome is a product of cortisol. And in this process, you have to determine if it's ACTH driven or not. That is the stimulus coming from ACTH, or is it coming from the adrenal gland itself? Cortisol messes with everything, and too much cortisol is going to cause you to become hypertensive and diabetic. Well, that's most of the patients we take care of. On the test, look for a woman who's hypertensive and diabetic, but who also has some of these features. You're looking for the buffalo hump, and this is a great one to throw up a picture of a person and show you the back of their neck, or purple striae from truncal obesity, stretch marks. Or they'll show you their face, where they have this really bad acne and their face is really fat, called moon facies. You see these things, purple striae, moon facies, buffalo hump, they're getting at Cushing's. And if you suspect someone has Cushing's, you're going to follow the advanced organizer, low, then high. If someone comes in with the signs and symptoms of Cushing's, you want to make sure that they indeed have Cushing's syndrome. To do that, you're going to do a low-dose dexamethasone suppression test. In this case, they're going to fail to suppress. Now, you have to back this up with something else, and whether that's a late-night salivary cortisol or a 24-hour urine is irrelevant, but you have to pick a second test. If it fails to suppress, it means they have Cushing's syndrome. Not necessarily Cushing's disease, but Cushing's syndrome. And now you need to know if it's ACTH dependent or not. ACTH then, low dose dex, then low, then ACTH then. If it is not ACTH dependent, that is, the excess cortisol is turning off the pituitary and there's no ACTH floating around, that is, the ACTH level is low, it is a primary adrenal tumor. You've already ruled out ingestion of corticosteroids. And now you know that because it's ACTH free, it must be primary at the tumor. So what you're going to do is get imaging, CT scan or MRI, confirm with adrenal vein sampling, and then resect. If the ACTH is elevated, it is ACTH dependent. And what you need to find out now is this coming from the pituitary or is it from somewhere else? Even though you have an adenoma producing ACTH, if it's in the pituitary, there will be some semblance of function. That is, you can get it to suppress. If it's coming from a cancer, cancer does whatever it wants. So what you do next then is a high dose dexamethasone suppression test. And if the high dose dexamethasone suppresses, that means it's from neural tissue. This is going to be Cushing's disease, the pituitary adenoma. Obtain an MRI of the pituitary and resect. If it fails to suppress, it means it's not from the brain. This is an ectopic tumor, usually associated with lung cancer. Get a CT scan to identify. We'll finish on an easy one. That was the adrenal gland, Cushing's, cortisol, theo, catecholamines, cons, aldosterone. We're going to finish off with coarctation of the aorta. In coarctation, you got your heart, the aorta comes off, and then somewhere after the great vessels, and it has to be after, because if this coarctation occurred before, you'd lose a limb or half your head and you'd be dead. So coarctation occurs somewhere after the great vessels, where the aorta simply constricts down. Now that's a huge resistor. So there's going to be a lot of pressure going through the great vessels. So the way the patient is going to present is with the torso or upper extremities that have really bad hypertension. But it's really hard to get blood to the other side of this, so their legs are going to be hypotensive. This usually does not present in adults. It usually presents in kids, and they'll have claudication. That is, they will refuse to walk because it hurts, so they'll stay crawling. You might also notice a temperature difference. Touch their arm, it's warm. Touch their leg, it's cold. And this is not going to be the hypertensive diabetic smoker who's 75 and got peripheral vascular disease. This is going to be the teenager or the young 20s who has nothing wrong with them otherwise, but has almost no flow to their lower extremities. In an adult, that temperature difference is legit, but it's probably not going to be claudication. In an adult, what happens is that to get blood flow to the legs, collaterals formed through the rib arteries. And so if you see rib notching on x-ray, that is to say, if they show you a picture of an x-ray in a secondary hypertension question, look for erosion of the ribs because the arteries have gotten so big as they're transporting blood around the coarctation. The diagnosis is made with an angiogram. These are generally not amenable to endovascular repair, and so you generally need to resect and reanastomose. All right, to review, coarctation, upper extremities hypertensive, lower extremities hypotensive, angiogram, resect. Cushing's disease, low then high, trying to figure out if it's a primary adrenal tumor, pituitary tumor, or an ectopic tumor. Look for the buffalo hump, truncal obesity, and moon facies. Theo, paroxysms, get the urinary metanephrines, treat with alpha blockade first. Con syndrome, separate out primary hyperaldo with an aldo-renal ratio greater than 20 versus renal artery stenosis with an aldo to renal ratio less than 10. Do stent women with fibromuscular dysplasia. Don't stent men with atherosclerosis. That is surgical hypertension. Become a better doctor. Subscribe now to get access to our premium content.